This is real life for many of our patients, but we never know it. They will only tell you what they're not embarrassed to tell you on our turf. But when we go into their home and the power shifts to them, they relax. They become engaged. They're open to education and they're open to help. And it just shifts everything. It changes the whole game.
Hello and welcome to the Dragon Tree Podcast, the show where we talk to great communicators about how they do what they do. I'm your host, Chris Hobson, and today we're talking with Colleen Hole. Colleen is a person-centered healthcare advisor working on the front lines of delivering value-based healthcare to patients. Today, we'll also be discussing the advantages to administering care to patients in their homes as opposed to brick-and-mortar hospitals, and the really effective messaging Colleen has employed with her team to advance their goals. So, Colleen, with that introduction, thank you so much for joining us today.
Glad to be here. Thank you.
Absolutely. Yeah, you travel around the country talking about this hospital at home approach to care. And that's actually where I became acquainted with your work, was on a Capitol Hill symposium not too long ago. And part of your advocacy work is talking about how to actually scale a program like this nationally. I was wondering if we could kind of start at the beginning today and we could take a minute to talk about, kind of how you got into healthcare originally, and maybe what about your professional journey kind of led you to this home-based care approach.
Sure. So I wasn't one of those little girls that dreamed of being a nurse. Back in my day, you were a teacher or a nurse or a mother. I would say I mostly aspired to be a mother, but thought I was supposed to go to college. So I sort of fell into nursing, and obviously 44 years later, know I made the right choice. But in nursing school, we learn a lot about holistic care. We learn about not just the physical assessment and care of a patient, but really all those things that impact health. And this was decades ago, but we learned about that. Unfortunately, when I found myself in a real hospital after graduating, it was largely about tasks, and there were a lot of them, and important things, necessary things, but all the things you have to do, meds, dressing changes, and hanging an IV, and all that nurse and doctor stuff. And I became a little disillusioned, frankly, that, wow, I don't actually have time to sit and listen to this patient and understand why this is his third visit in as many months and what's going on. There just frankly isn't time for that in most of our traditional structures. So I still loved it, and did acute care nursing, hands-on for about 10 years. But when I had the opportunity to enter leadership, and actually we opened a new hospital on a very innovative team-based care approach and more patient-centered than anything I'd seen, I jumped. Around that time, 1992 or so, patient-centered care became the watchword. And we all talked a lot about it, but as I said, our health system isn't really built for it. So we did our best. I think we made great strides over the next decade to be more patient-centric, more holistic. But again, we were stuck in structures that largely were built around places, hospitals, clinics, surgery centers, or payers, frankly. We often do what we can get paid to do. So here comes the pandemic. Over those 40 years or so, as I mentioned, I spent a lot of years in acute care, 30 probably in total. I managed ambulatory clinic practices for several years and really learned how that outpatient world works. I was given the opportunity to open our virtual ICU, so I really got a taste of the opportunity to leverage technology to deliver care, where it was primarily a virtual service. Then I spent a number of years in population health, where I recognized and learned about value-based care and really got turned on to end-of-life care and palliative care and how we can help seniors especially live better and longer. Then the pandemic hits, and literally I was called to a meeting on March the 20th. We recognized we were about to get hit with far more patients than we had capacity for. What are we going to do? And like any crisis, you pull up what you have on hand, and, sort of like one of those Apollo 13 moments where, the crew's up in the air and we only have this, and this is all we got to work with. So we had experience with virtual, which I'd mentioned. We had done virtual visits with providers for years. We had a very robust but small community paramedicine team, also known as mobile integrated health. And then we had a number of nurses and physicians on standby as we had shuttered several services as patients were afraid to come in. And we set off. We started seeing patients just a little over a week later. We did not worry about payment. We didn't have time to even think about issuing, let alone processing a claim. It was literally survival to decompress our already very full hospitals. And we saw 2,300 patients in about 12 months, never issuing a single claim. So, leveraging all of that learning in March of 20, and actually, I'll mention the waiver was issued by CMS actually in November of the prior year. We implemented ours just a few months
Oh,
later and set off to be funded, thankfully, by Medicare, which is a fair portion of our patients. So I can keep going, but I think you probably want me to hush. But that's I guess I should say my passion that I built up over decades finally had a place to go when I had a chance to implement this care model, and I'll talk more about it shortly. But in the home gives your best chance ever to deliver on that promise of holistic person-centered care.
now I'd like to pivot to the hospital at home program. Can you talk a little bit about just how it evolved into its present forms and kind of what are the goals as you see for it?
Sure. And I always mess up who invented this, but they said something like never waste a good crisis. As I mentioned, we were in a failure, not an option mode when the pandemic hit. Our hospitals historically are full in the winter with all the viruses that float. And there was already crowding in our EDs. We were, already in our usual state of full. And here comes the pandemic. And we were estimating as many as 200% increase in need. So, what are we going to do? This was before the waiver was implemented by CMS. As I mentioned, and I think this got in that earlier part, real quickly stood up the program in its most primitive form, just using what we had, virtual capabilities and a strong community paramedicine team, and started seeing patients. It was all about COVID, but they were really sick COVID patients who would have otherwise been in a brick and mortar bed, which I mentioned we did not have. And so we were able to take care to the patients. We talk about a lot about care delivery. We don't actually deliver care, but we did in this model. We actually delivered care to the
Right.
patient. They loved it. They felt safe. They felt cared for. And honestly, as you know, many patients passed away with COVID and they were able to be with loved ones instead of in a hospital. No, we didn't lose a lot of patients, but still really proved to me or reaffirmed what I knew about healthcare. And that is, it is personal. When you think about a hospitalization, and this is in no way a slam on hospitals, as I said, I spent most of my career there, and we will always need them. Thank goodness we have them. But when you go to a hospital, you give your power away. You are told when you will eat, when you will sleep, when the lights will be on. They give you a beautiful hospital gown, when you're going to take your medicine. And you, at your age, can usually manage that. It's disruptive, it's uncomfortable, but you basically put your life into the hands of strangers.
Right.
Imagine that as an 80-year-old who already is perhaps already fairly ill with chronic disease, how disorienting
Of
that must
course.
be
Of
to
course.
them. So, hospitals, I hate to say it, and our marketing folks have always hated me to say, they can be very dangerous places for particularly older, fragile patients. Care in the home, as you just said, it shifts the power back to the patient where it really belongs. The patient is in a familiar and comfortable environment. They know their own way to their own bathroom and their refrigerator. So you decrease the risk of falls, certainly the risk of infection. Delirium is common among older patients who get confused in these unfamiliar surroundings. And just being around loved ones and how therapeutic is their pet.
Right.
We actually bring pets, dogs into hospitals under a pet therapy program because we all know how healing it is to be around pets and animals. So the home really allows us to combine what we know about the value of healing in your own personal environment with all we now know from science and research, and then layered on technology. It's the best of all worlds.
Absolutely. And it's just so interesting how the more things change, the more they stay the same, like we were saying. Very interesting. And
Yeah.
it's probably gotta be so rewarding because that's kind of why it sounds like you got into this career field in the first place. So it's great that you've kind of come full
It
circle.
it really it really has come full circle, not just for me personally, but I think for the American healthcare system. Other countries have been delivering hospital at home services for decades. We're kind of behind in that. Some of it has to do with payment. They have more socialized medicine programs in other parts of the world, and it creates better alignment of goals when you align payment with care. We're not there yet in most markets in America, but I think someone once said, you can't put the genie back in the
Right.
bottle. I really think we've gotten a taste of what could be in our American healthcare system. And why I met you on Capitol Hill, increasingly our legislators agree. CMS really has seen and published on the value of this model for patients. And at the end of the day, that's what I care most about.
Absolutely. Yeah, and that idea of patient-centered care melds so well into the concept of the home-based care, which we'll talk about. Some very much a Venn
Absolutely.
diagram, overlapping diagram there. Who were the stakeholders involved on some level, and how did you modulate your messaging to all those different groups?
Right. So, interestingly, in a crisis, people just want to help. There's a great helplessness. You feel like, is there anything that I could do to help? And so, honestly, I didn't have to spend a lot of time convincing and selling the idea. Our head of, he was our physician executive, Dr. Scott Rissmiller. I think you met him on Capitol Hill. He went to our president, Gene Woods, and said, "Hey, we have to do something. Here's something that could work." And Gene said immediately, "Go." So today, most health systems trying to implement these programs are having to spend a lot of time and energy convincing the C suite of the value of this because it still feels foreign. But in that moment, this was a absolute imperative
Right.
go. And that actually trickled all the way to the front line. Again, I can't tell you how awful the pandemic was, but what a blessing it was to knock down traditional silos in hospitals where once Gene Woods said go, and we put this plan together in a few days, all it took was a phone call to pharmacy to say, "Hey, we're going to have to get medicine to these patients. Can you help?" Yes. Respiratory therapy. We need therapy. We need consults. Can you help us? Yes. We've got to figure out how to get oxygen because most of these patients were on oxygen. Far more oxygen needed than we had in usual
Oh, wow.
supply
Okay.
inventory. They figured it out. I mean, it was an opportunity to actually coalesce around a goal that we leveraged that moment. And not that it was a conscious thing, but we rode this tide of urgency where everyone felt like I could do something. We literally had vice presidents who had nothing to do with clinical things come in and help us package patient thermometer, pulse oximeter, educational materials. Here's how you use your oxygen in these packets, Ziploc bags in a warehouse. And some of them brought their kids. I mean, it
Wow.
was just a moment to do something that would be helpful. So, again, we were almost unconscious of what was happening. It was in retrospect, about a year later, when I looked back and said, wow, I think I've witnessed a miracle here. We've seen something that just doesn't happen.
Right.
And again, as I alluded to, our health systems are largely built on place, hospital, clinic, ambulatory service, surgery center, payment. If I do this, I can get paid. If I do it this way, I can't. And then professions, even. This is what doctors do. This is what nurses do. This is what paramedics do. So we have somewhat artificially divided up the care continuum And most importantly, we've divided up the patient experience around us. And this blew that up. So you can tell I'm a little excited about what happened. But then to your point, so what? What
Right.
happens then? So I will be honest to say, as the pandemic would wax and wane, I felt kind of excited that I got a new life, another injection when the COVID cases would go up, because I knew I could continue to make my case for the program. As the cases would, as they did a couple of times, fall back off, started getting questions, appropriate questions from the CFO, even from some of my clinical leadership. You sure we still need to do this? It's not really about COVID anymore. We're doing okay. We're going into the summer. The census falls anyway. Why are we going to need this? I was a little bit of a dog on a bone. I really knew in my heart it was the right care model. And you can tell I'm toward the end of my career and I had nothing to lose by pushing. And so just kept on making the case. So I used patient experience data. We surveyed our patients. They loved it. That's important. One of our strategic initiatives is around health equity. I used it and not unfairly or incorrectly. When we go into the home, we can actually see the truth about how well or how poorly our patients are living and put our money where our mouth is. We can actually do something about what we find, which is sometimes food insecurity. The refrigerator's empty. The patient told us in the ER that they've got their medicine, and we go and find an empty pill box.
Right.
Or it's 95 degrees in the middle of summer in Charlotte. They have no air conditioning. This is real life for many of our patients, but we never know it. They will only tell you what they're not embarrassed to tell you
Right.
in on our turf. But when we go into their home and the power shifts to them, they relax. They become engaged. They're open to education and they're open to help. And it just shifts everything. It changes the whole game. So if you want to talk about health equity and really meeting the patient where they are in the rhythm and context of their own life, we have to go to them instead of forcing them to come to us. So, long winded, just started knowing I've got to tell people, I got to tell a story. I used data to talk about the volume of beds created because we were still capacity constrained, not as critical, but still full, able to say we've saved this many thousands of bed days. We've got the patient experience scores and they love it. And then the story, sending anecdotal stories up to the C suite. Look how much of a difference that we're making. But then, as COVID really calmed down, it was evident that we had earned and learned a lot about how to care for really sick people at home. So we started looking at other diseases, heart failure, COPD, numerous infections that would routinely keep a patient in the hospital for antibiotics and wound care, and really just opened the floodgate, not by disease specifically, but if your patient needs these things, this is what we can deliver. Doesn't matter what the diagnosis is. So, really, we've now cared for well over 150 diagnoses. We've never limited that and can do almost anything that would happen on a general med surge unit in a hospital, short of just a few things. We don't do invasive procedures. We sure don't do surgery, but pretty much
Anything
everything else.
short of
So
that.
it's now become still a capacity management strategy for our health system, but more intentionally tied to health equity and access and really a number of
Yeah, I
strategies.
love that. I love the storytelling aspect of this because you obviously use data to tell a very compelling story. And I just, that's if for viewers who've watched past episodes of this podcast, they'll know how important I think data is, and just as important in other fields. I mean, health, if not more so, because healthcare, in my experience, is such a change resistant industry that it really helps to be able to bring that story to life with data and real numbers,
Yeah.
especially for the C-suite.
I often say data will sell, but data will tell, but a story will sell. And it's also what's memorable. We've all been a patient. We
Right.
all have hopefully positive, but we've all had a few where we just the friction points in healthcare. If you can tell stories, particularly from a patient orientation, that's memorable to all of us, including the
Right.
CFO.
Yep, that's that human connection that, as good as data is and helpful as it is, you wanna carve out that space for the humanity too. So I think it sounds like you strike that
Right.
balance. So before we get any further in the conversation, Colleen, I was hoping you've set a really good, background and groundwork for what the program is, but can you paint a picture for when you actually go out, or, the people who go out into the homes? I understand there's the kind of like a fleet of SUVs that are equipped with all the kind of equipment you talked about earlier. Can you just maybe just give a sample, a kind of a brief overview of what it actually looks like when a unit is deployed into the field to someone's home? Like what actually happens?
Sure. So we started out with just a central hub where our community paramedicine and and really all of our mobile medicine lives, if you will, a huge warehouse where that system is
Right.
maintained. We now have substations, if you will, north, south, east, and west of that because our geography is now covering 14 counties, and it's inefficient to try to dispatch from a central location. But at all of those sites, the fleet, if you will, their SUVs, fully stocked with clinical, care supplies, dressings, IV tubing, all of that, a fairly large medication supply. That's not the main source of the meds; they come from the hospitals. But when a med gets changed or added, oftentimes they carry that there. In our model, we use almost exclusively community paramedics, partly because we had them already, though we have gone from about 10 to 50 of them. But also, I think they are uniquely trained and experienced to deliver what we need. And that is fearlessly going to any community, rich, poor, urban, rural, doesn't matter. Think of how they train. They have to go everywhere. They're fearless because they have to practice autonomously in the field with often not a lot of support around them in any setting. They can start an IV anywhere on anyone, anytime. And when they face a challenging situation, they rush in. They don't retreat. They load up their vehicle. They're assigned average 4 patients, but they see each of those 4 patients twice. So they'll make 8 visits in their 12-hour shift, go to the home, and spend on average 45 minutes, but sometimes as much as an hour or more, depending on what the patient needs. I dare say that's more time than a patient gets in a brick and mortar hospital with a bedside caregiver. But when they're infusing that antibiotic, they sit at the bedside and they learn a lot about the patient's family, what matters to that patient, what are their barriers to staying well. We've learned incredible things that we were actually able to do something about. They deliver that care. While they're there, they do a full assessment of the patient, report those findings to our virtual physician who is standing ready to do their intervention, which is a virtual visit. So we've got technology in the home, sort of like an iPad with a two-way audio video connection with the patient. They have a help or call bell button on that tablet. They also have a wearable device on their upper arm that tracks all of their vital signs, including pulse oximetry. All of that tech and data helps inform the plan of care, along with the report from the paramedic and the nurse's report of his or her twice daily assessment of the patient. So the virtual visit happens with the provider just like it would if you were in a hospital. The paramedic is physically there. The nurse is also there on camera. So our three-legged stool is wrapped around the patient. And a beautiful thing is often the family is right there listening in as well. That visit by the virtual provider happens at least once daily, but that paramedic will come back in the afternoon and make a follow-up in-person visit with the patient. And all is documented on the inpatient record, just like in the hospital. It's all connected through technology, through
Right.
our EHR. and through communication within the care
Right.
team.
Yeah, and like you just said, communication with the care team. When I talked about that symposium earlier, it was last week actually. I think you it was so neat because you had your presentations, but then you had literal people who are on the team displaying and presenting on how all this works. So I actually had the opportunity to sit down and interact with the doctor, the nurse on the iPad, and it was just so eye opening. It's like, oh my gosh, like, why haven't we been doing this forever? We've had the technology for gosh knows how long now. But yeah,
Well, I'll tell you why we haven't, and it's largely because we're risk averse.
right,
You kind of said
right,
that
right.
already. Health systems and maybe any large industry like that, it works, and we know our warts, and we do performance improvement around those things, but honestly, we don't transform often.
Mm.
And I'm not sure that we would have even now had it not been for the pandemic that forced our hand. So I go back to it was horrible, but I'm thankful that it pushed us to do something radically different.
On another podcast, I heard you talk about the fact that, in keeping with the idea that home-based care is a lot of times more affordable than brick and mortar care, you talked about the fact that there is the current aging population of the United States is pretty much the biggest generation we've ever seen. So and the generations that follow that are much smaller. So I think you made the point that if we were to build based on how fast some of these metro areas like Charlotte are growing. If you were going to build a hospital out to account for the care and the acute care that large aging generation would need, by the time unfortunately that generation would pass away, you'd almost be overbuilt for the generations that follow it. So I was wondering if you could talk a little bit about that.
We are in a growing market, and not every market in the country is a growing market, but the South and our North Carolina, Charlotte, North Carolina market particularly, they're adding, I think I heard 110 people move here every single day. The cost to build a hospital is running between $2 and $6 million per bed, depending on how much tech you want to embed in the room. So, I mean, just think about a 20 bed hospital at 6 million bucks per bed. We are currently building a 34, I think, bed hospital at $175 million. And as you suggested, the baby boomer generation is coming in a tsunami, carrying more chronic disease into those senior years than we'd seen in prior generations. And so the demand for acute care is going to go up partly because of population growth, but also in every market because of the high demand acute care needs of this baby boomer generation. And not to be cynical, because I'm part of it, but we're not going to be here in 30 years. And the generation behind us is significantly smaller. So, does it make sense when the GDP on healthcare is about 20, the percent of the GDP of healthcare is around 20%? It fluctuates, but why would we do anything that is just going to increase the cost of healthcare? Couldn't we save that capital, the time and expense of capital, and really double down on these kind of less costly, ultimately, care models? It doesn't cost $170 million. In fact, we're running a census in the mid 70s right now, and we aspire to be at 100 in a couple of months. And beyond that, the sky's the limit. We can take care of a lot more patients in this model than we can by continuing to build.
Colleen, we've mostly talked about the upside of care based in the home, and I wonder, we haven't talked overly much about the challenges that people face when trying to administer care in someone's home. And what I mean by that is maybe there are certain populations where maybe traditionally they don't trust healthcare as quite as much, and that kind of runs the gamut. So, have you encountered any obstacles when trying to administer home-based care? And if so, what are they, and how have you overcome them through things like your messaging?
Yeah. Unfortunately, despite our best efforts, some don't trust healthcare. They fear healthcare itself just from I'm afraid of needles and blood. There's that. But also, generations ago, you trust the preacher and the doctor, and and the government. That's just not true anymore, particularly among some ethnic groups with good reason, because you will see, if you look at data, significant health disparity. So, particularly related to outcomes. So, I think we have to hold up the mirror and say, what's this? How's this happening? And what part of this is ours to own? And it's some of what I've already talked about. We built the health system around us and not the patient. Even language like non-compliant, where we call a patient who isn't taking their medicine non-compliant, that is laden with bias and judgment. And we're becoming increasingly aware of that. So I'm proud of the efforts to do that better and more compassionately. So using words like not adherent, even that I don't love. But what we find by going into the home, and as I've said, often it's not that they didn't want to get their medicine, they didn't have a way to get to the pharmacy, and or they couldn't afford it, or we did not a great job of educating on the why you need this medicine. But I think I go back to the power shift overall. When you are invited into someone's home, one of our physicians called it a sacred trust. This is something beyond, I'm going to come in here and give you your, dressings and antibiotics. Just think about when you invite someone to your own home. That's special. And on my turf, I can breathe, I can relax, and that starts that engagement, which makes them open to education. And then, best of all, we've empowered the patient to begin to manage their own health with our help. So I think just shifting the location of care to the patient, we break down those barriers and build trust back. And we've seen it proven out. I will mention our ethnic and racial demographic mix is exactly the same in hospital at home as it is in brick and mortar. And that we're very intentional about that. Some, even in legislator positions, have suggested that this care model will only cherry pick the healthy, wealthy patients, the elite, that you're just going to save this for those who can afford it. Others, conversely, have accused some of dumping the poor, dumping the least of these. Neither are true. And we make sure we can prove it through data that it's not true. We really do track and trend that. And it, quite honestly, it happens very naturally. We haven't had to target, certain groups. It's happened. But I think those groups, those disadvantaged groups, are disproportionately, I hate the word harmed, but perhaps harmed in traditional systems. This is the best chance I think we have of getting it right and rebuilding trust.
Yeah, and that really that's so interesting, and that really comes through in your payer mix of payers that are actually involved in the
Yes.
program. And it's Medicare, it's Medicaid, it's private insurance, but also you've got a fair number of patients, if I understand correctly, who are either underinsured or just don't have insurance at all. So I was wondering if we could talk a little bit about incentivizing the care to be delivered, and also like how do you actually fund this? Because I know there's probably people sitting here saying, well, this is amazing. I would love to, whether they be a physician or other kind of caregiver, I would love to be able to do this where I practice. But oh my gosh, like the how would we fund this? There's a waiver. Who knows if it's going to be extended or not, like we're going to talk about. But can you talk a little bit about how you build that care around people who maybe are either underinsured or uninsured, and how do you fund that?
Well, our health system historically has cared for the least of these. In fact, our mission statement says for all, hope, healing for all, health, hope, and healing for all. And we mean it. We give away millions of dollars of uncompensated care every single day. So that's really, I think, in the DNA of Advocate Health. But I will say, Medicaid, you mentioned that specifically. has been pretty tentative about covering. In fact, only the number moves a little bit, but about 10 of the 50 states are covering through their Medicaid program. Most are not. A little bit of it is watching to see what happens with this acute care at home waiver. And we think that will help nudge some of them forward. But most of them are in a waiting and watching mode and have some concern about health equity. As I just mentioned, I think it's wrong. I know it's wrong, but there is some of that. Um, the unfunded, uninsured patient runs around 9-10% of our patients. They just can't pay, and we will never turn them away, ever. In fact, they are probably our greatest need patient that needs this extra level of support and care. And we are finally able to actually address some of the needs that keep them circling back to the emergency department. So that whole social determinants, I like the word social drivers of health issue, we can address better in these care models than we can in our traditional structures. Um, how do we pay for it? The CMS Medicare, and it's the Medicare fee for service only, not the managed Medicare Advantage plans. That gave a huge lift. Medicare is paying a full inpatient DRG payment, whether the patient is in the hospital, brick and mortar, or a hospital at home. Very unlike what I think our government has traditionally done, and I am eternally grateful. It is a waiting and watching game for commercial payers. We have some commercial payer contracts. We're working on others, but I think every payer is waiting and watching to see what happens with Medicare, this acute hospital care at home waiver. We have a lot of work to do still. We need to create benchmarks, quality outcome benchmarks to which we all, aspire. We need to better define the care standards because each health system has implemented it slightly differently, but our outcomes are great. And so there's a great momentum. So funding, back to your question, is still a little bit up in the air, but we are in regardless of that, partly because we know we will have a capacity problem for the foreseeable future.
Thank you so much for that assessment and helping people understand how these programs work. And something I also was wondering is about your community partnerships. I saw that on another podcast you were talking about. I just wonder real briefly if you could talk about, I think there are groups you work with, like say food kitchens or a home home improvement stores that will volunteer either their time or resources. Can you talk a little bit about that? Because I think that also bolsters your ability to go into people's home and not just help with the healthcare part of it, which I know you do a lot of maintenance, and that's its own form of prevention, which is great. But you also address, like you talked about the social drivers of health, like maybe somebody's roof is leaking, or maybe they need a bar in their bathroom, their bath, so they don't fall. So could you talk a little bit about those and food? Having enough food and nutritious food. So could you just, as we close here, talk a little bit about that part of your work?
Absolutely. And again, that lingo, SDOH, social determinants of health, it's leaning more towards social drivers of health because determinant sounds like fatalistic. But the point of that is, and again, this is relatively new language, but it goes back to the whole person care. You can prescribe a medication or fix their hip or whatever, and you send them right back into the situation that created the problem in the first place. We're actually reacting, not proacting to help patients live better. So, as we go into the home, learn the truth about how well or how poorly that patient is living, we can actually do something about those things. When you're in a hospital, we're going to feed you. You might not like the food, but you will be fed. We will ask the question because we should, do you have food in your home? And they will always say yes. I mean, it is so rare that a patient is going to tell you something different because it's embarrassing to admit. But we go in, we find that the refrigerator is essentially empty. They don't know where their next meal is coming from. We take food to them during their hospital stay, but more importantly, connect them to community resources to assure that they have ongoing food
Right.
security. And that's something just our traditional structures just don't hardly allow for. We've got great care managers and social workers, but their visibility is limited because they are, I often say, you don't know till you
Right.
go. And when you go, you know. Similarly, we evaluate the home for safety. Rugs on the floor that could cause a fall when they slip, shower bar to keep them from falling in the shower in the tub. All of those things seem so simple, and quite honestly, they're not very expensive, but not usually addressed in a traditional episode of care. So yes, partnering with, and I won't name names, but they're out there, food banks, improve home development companies, um, anyone that can help us in this space, and those partnerships are continuing to grow. It used to be health systems, and I do it personally. I can do this by myself. We've got this. We recognize now we can't do it all, and so how do we partner with like-minded, caring organizations that just want to help? And it's
Mm.
beautiful, actually.
That's really outside the box thinking, and that's only recent. I've I've worked kind of tangentially in healthcare for over a decade, and I know just within those 10 years, the idea of social drivers of health kind of being upstream from clinical outcomes
Right.
is really taking hold. So I'm glad that
Really
you all are
important.
already on that page. So in closing, Colleen, where do you see the future of the hospital at home program going? Maybe just at advocate, in specific, but in general, in the country.
So within Advocate, we started in the Charlotte, North Carolina market, have grown really to be the largest hospital home program in the country. We've cared for over 13,000 patients to date, running a census in the mid 70s, and we'll be at 100 in just a few short months. And beyond that, literally, there is no end. Some would suggest, and I think it's true, that about 20% of a market's beds, acute care beds, could be cared for in this model. And I absolutely believe that to be true. But that's the Charlotte market. We also have a great program in our Wake Forest, Winston-Salem market that we plan to enhance into an inpatient service. It's really an outpatient service right now. That's underway. And then, as you know, we were our Atrium Health in the Charlotte market, but now part of Advocate Health. We're looking at hospitals in the Illinois and Wisconsin markets. Where is there great opportunity there? And we'll likely start in in regions that already have a capacity challenge. It's a lot easier to make the business
Right.
case, frankly, if you've got a capacity challenge. And they have those. So that's really the next frontier as this team expands and has their sights on other markets where this would be beneficial. That's the Advocate dream. That's Gene Wood's dream. I would even call it a plan. The rest of the country, over 300 hospitals have been granted the acute hospital care at home waiver. Around half, and I think it's actually less than half, have actually implemented for a myriad of reasons. They missed that crisis window that we jumped through, makes it a little harder to make the case. They are waiting to see what happens with the waiver. If it doesn't continue, really harder for most to stand up a program. We were able to leverage a lot of what we already have and didn't have to add a lot of net new resources to do this other than the clinicians. But most will have to buy a fleet of vehicles. Most will have to buy, a place to keep inventory. And so it's a pretty heavy lift to start from scratch. And so that's a huge barrier, I think, for most health systems. But my work from here, as I enter my own kind of next phase, is to help raise all boats. I want to go and help health systems figure this out. Not that I'm the only industry expert, not at all, but probably have the lion's share of experience, particularly in this area of how to do it at scale. And another saying I have is if you don't scale, you will fail. It's really hard to run a program with two or three patients. It's just you just can't make it work. So I want everyone to win, and excited to continue to advocate at the legislative level, communities, health systems, whoever wants help.
Yeah, and we'll go ahead and in the show notes include your website. You're going to become a consultant here pretty soon, and that kind of leads to my next question, which is, if anyone wants to continue this really important conversation, Colleen, where should they find you? Just go to your website, or
Yeah, yeah. I have a website almost ready for prime time, and will be available. That I'll have a form to fill out there if they want me to get in
excellent.
touch.
All right. Well, Colleen, thank you so much for your time today. It's been fascinating.
Thank you for having me, Chris.
Absolutely.
Have a great day.
You too. Thank you.